Today we'll be discussing a little bit about periodontal flap. I'm Dr. Belim Wasim Siraj from Department of Periodontology from Yenepoya Dental College. So what is flap? So basically flap is a section of gingiva and or mucosa which is surgically separated from the underlying tissue to provide the visibility and access to the bone and the root surface. Okay, now how do we classify this periodontal flap? So it can be classified based on the exposure after the flap reflection. So that can be a full thickness flap or it can be a split thickness flap. Also it can be classified based on the management of the papilla during the flap reflection. It can be a conventional flap or it can be a papilla preservation flap. Also there is another way we can classify the flap, which is the placement of the flap after the surgery is completed. So that is a non-displaced flap or the displaced flap. Again, this displaced flap can be classified into apically displaced flap, coronally displaced flap and laterally displaced flap. Okay, coming to the full thickness flap, that is one of the classification of the flap based on the exposure of the root surface. So here, as the name suggests, the full thickness of the tissue is elevated or reflected. So here periosteum is also reflected to expose the underlying bone, which is indicated in case of regenerative procedure or resective osseous surgery. So basically this type of flap is reflected whenever we need to access the bone, whenever we need to perform a surgery or a procedure which involves the alveolar bone. It is where this kind of flap is indicated. Contraindications are area where the treatment of osseous defect or mucogingival problem is not required. A thin periodontal tissue also is a contraindicated for this type of flap because it may end up causing osseous fenestration. Also area where alveolar bone is thin, we will avoid using this kind of flap. The next is partial thickness flap. As the name suggests, the flap is the periosteum attached to the bone is not elevated or reflected during this procedure. As the schematic diagram also represents, we only remove the epithelium and the underlying connective tissue, whereas we leave the periosteum attached to the bone. So that is why it is called a partial thickness flap or a split thickness flap. Here the periosteum covers the bone which is remain intact. It is indicated when the flap has to be positioned apically or coronally or laterally. Okay, when the operator does not desire to expose the bone is also one of the major indication for this kind of flap. Next we have classification, as we saw, management of the papilla during the surgical procedure. So we have a conventional flap. Okay, here the interdental papilla is split beneath the contact point of the two approximating teeth to allow the reflection of buccal and lingual flap, as the image shows surgical images where the papilla is split between two teeth so that we have a two separate papilla, one is on the buccal side, one is on the lingual side. Okay, the interdental space are too narrow is where this kind of procedures is indicated, or the flap is to be displaced is also where this kind of flap is indicated. The modified Widman flap, the undisplaced flap are some of the example for these kind of flap procedure. Okay, then we have the modified flap operation. Now we are coming to the individual flap procedures. This flap was first described in 1931 by Kirkland. It is used for the debridement of the periodontal pocket as well as removal of the periodontal pocket. This procedure was called modified flap operation and basically is an access flap for proper root debridement, as we already discussed. So here the procedure is very simple, as the diagram shows. First we place a clavicular incision in the affected teeth. We reflect the flap without making any releasing incision. We carry out our instrumentation and we suture the flap back to its original position. Okay, so this is basic idea of your modified flap operation. Then you have an original Widman flap. As the name suggests, it was described by Widman. It is a flap designed to aim at removing the pocket epithelium and the inflamed connective tissue, thereby facilitating optimal cleaning of the root surface. Widman pointed out the importance of placing a soft tissue margin at the level of the alveolar bone crest so that the no pockets would remain. So here the idea is again to remove the pocket lining and place the flap at the crest of alveolar bone. So here, how do we proceed? We start with the clavicular incision as we discussed earlier. With that, we also place two vertical releasing incision. Now, once we have this, we reflect the flap, we carry out our instrumentation. If at all required, we carry out our osseous procedures and then place the flap back to the position at the crest of alveolar bone. This is how we perform the Widman flap procedure. Then we have a modified Widman flap, which is a modification of original Widman flap given by Ramford and Nissel, okay, in the year 1974. Here, the procedure is again very simple. There are three main incisions that are given that needs to be remembered in this particular procedure. Okay, first incision is a clavicular incision that we give into the gingival sulcus or the periodontal pocket. The second incision is a horizontal incision that is given at the clavicular, second incision is given at the crest of the gingiva, and the third incision, that is interdental incision, is given, which will create a collar of the tissue which we remove at the end of third incision. Finally, we reflect the flap and then carry out our instrumentation and proceed with the suturing. Then we have a next flap, that is papilla preservation flap. As the name suggests, here we try to preserve, or we try to not cut the papilla in or split the papilla. The papilla preservation flap incorporates the entire papilla in one of the flaps. So it can be on the buccal side or it can be on the palatal side. The indications are when the aesthetics is of concern, where bone regeneration techniques are attempted, or also whenever there is a midline diastema. Okay, the advantages of this procedure is aesthetically pleasing. It primarily coverage for the root graft material that we have used. Some of the disadvantages are technical difficulty, and this is a time consuming process. Okay. Based on the flap placement after the surgery, as we discussed, we have undisplaced and displaced flap. So undisplaced flap, when the flap is returned and sutured in its original position following the surgical procedure, is when it is called undisplaced flap. Most frequently performed type of periodontal surgery. It differs from the modified Widman flap in that the soft tissue pocket wall is removed with the initial incision. Thus, it may be considered as internal bevel gingivectomy. Here, all we do is we place the clavicular incision, or at times when the tissue is thin, we place the incision at the crest of the gingiva, and following which we reflect the flap, we carry out our instrumentation, and then we suture it back to its original position. Then we have a displaced flap. When the flap is placed apically or coronally or laterally following the surgery, it is thus it is called the displaced flap. So, following are some of the diagrams, one of which is apically displaced flap, where the procedure is performed, the instrumentation is done, and the flap is sutured from its original position, apical to its original position, is when it is apically displaced flap. The second image shows that surgical photos where we see a flap following which the surgical procedure, it is been sutured coronally to its original position. So we have a coronally displaced flap. Okay. Then we have a distal molar surgery. The treatment of periodontal pockets on the distal surface of terminal molar is often complicated by the presence of bulbous fibrous tissue over the maxillary tuberosity or prominent retromolar pads in the mandibular area, as we can see in the diagram. A typical incision designed for a surgical procedure distal to the maxillary second molar is something like this, where we have a two parallel line running at the distal end of the molar reaching to the maxillary tuberosity. Okay. Incision designed for surgical procedure distal to the mandibular second molar. These are some of the example of those incision. The incision should follow the areas of greatest attached gingiva and underlying bone. Then we have a triangular distal wedge procedure, where a triangular wedge incisions are placed, creating the apex of the triangle close to the hamular notch and the base of the triangle next to the distal surface of terminal tooth, as we can see the schematic diagram as well as the surgical diagram. Linear distal wedge is also another technique which we use for tooth. The linear distal wedge incorporates two parallel incisions over the crest of the tuberosity that extend from the proximal surface of the terminal molar to the hamular notch area. The distance between the two linear incisions is determined by the thickness of the tissue. As we discussed and we saw previously, there are two parallel incisions are given distal to the last molar, and then the distance between the two parallel incision depends on or determines by the thickness of the tissue that we have. These are some of the example where we place, there is a pocket that is distal to the molar, and then we have placed an incision or designed the incision and will follow up the surgery. Okay, as we can see the surgery, two parallel incisions are given, tissue wedge of the tissue is removed, then instrumentation is carried out. Okay, these are my references. Thank you.